right. So we're gonna talk about testosterone and its role in women's health. We'll discuss low libido, what's causing low libido, and what kind of treatment options we have available for this problem. So the old thinking was that testosterone was the male hormone and estrogen was a female hormone. But things are changing, and we're learning more and more about the role of testosterone in women's health. And I'll share some of that information with you today. So, some of you will be surprised to find out that if we convert testosterone and estrogen in the same measurement units, that the level of testosterone will be much higher. For example, in premenopausal women, the level of estradiol is around 150, and level of testosterone is almost 3 times of that. So not only we are estrogen-driven creatures, but we also testosterone-driven creatures. So when we check your blood work, we order total testosterone. So total testosterone is the combination of bound and free testosterone. So most of the testosterone in the blood is bound to sex hormone binding globulin, and in this bond, it's completely inactive. A smaller portion of testosterone is bound to albumin, and it's partially active. And only 1 to 2% of testosterone is free, and that's the one that exhibits the majority of the activity. So the higher level of sex hormone binds and globulin, the less of free testosterone we have available. And this is clinically relevant because there are some medical conditions and the medications that can raise sex hormone binds and globulin. So example would be birth control pills or antidepressants. And so that's the reason why we check total testosterone together with sex hormone binding globulin. Now, we don't see the abrupt drop of testosterone around perimenopause or menopause in the same way that we see with estrogens and progestogens. So the blue bar over here, it's the level of testosterone. And you can see the peak is around 20s, somewhere in middle, late 20s. And then it starts gradually declining over the lifetime. And there is actually a small rise around age 65. So something to look forward to as we age. So we know that testosterone plays important role in sexual function for the women, especially libido, but there is much more. So testosterone receptors, so those binding sites for testosterone, are located in different organs and systems such as heart and brain, muscle and bones, urethra and bladder. And we know that testosterone is linked to the health of those organs. So what do the current guidelines say about use of testosterone in women? Most of the guidelines agree for testosterone use for the low libido. We have a fancy phrase for this low libido. We call it hyperactive sexual desire disorder. And so if we go into specifics defining this, it's an persistent or recurrent deficiency or absence of sexual fantasies, lack of desire for sexual activity, causing marked distress. Sorry. So basically, it's an low libido that is causing significant distress. So this is the clinical diagnosis. So it would be a woman who used to have sexual desire or sexual fantasies, either spontaneous or in response to sexual clue, and now they are gone. And she's very stressed about it. So she feels less about herself, her relationships are strained, and she really would like to get that back. So there is no blood work that we can do. Sorry, so there's no blood work that you can do to confirm the diagnosis, and there's no cutoff for testosterone level. So, what is causing low libido? So, when it comes to female sexual dysfunction, it's a complicated matter. So, there's a biology, psychology, social, interpersonal factors that play a role. So, let's look at some of the causes. So, we have neuroendocrine imbalance. So, basically, there's imbalance in hormones and chemicals inside the brain that lead to increase inhibition and decrease excitation. Some of the physical conditions, such as breast cancer, diabetes, genitourinary syndrome of menopause, medications, so common medications are accessorized. Psychological factors, anxiety, stress, and also relationships, the conflict or lack of trust, and cultural and religious background. So we know from many studies that testosterone is very effective for low libido, and I want to share this study with you. So this type of study called meta-analysis and systematic review. And if you rank studies based on their quality, this is the highest quality you can get in research. So researchers looked at 36 randomized controlled trials with over 8,000 women. And what they found that those women who were taking testosterone, not only they had increase in libido, but also they had improvement in many other sexual function domains. So satisfactory sexual event frequency, pleasure, arousal, orgasm, responsiveness, and self-image, all the good stuff. And also they have reduced sexual concern and distress. So, who would be a good candidate for testosterone treatment? So, we have most of the studies on postmenopausal women, and it could be natural, it could be surgical menopause. But we also have some data on women in a late reproductive age, and this particular organization supports the use of testosterone in this age group. So, what about side effects? So, I should say that testosterone use overall is safe and side effects are mild. So, oily skin and acne, facial hair growth, hair loss and thinning in the places we want it to be, and skin irritation on the side of application. Some of the rare side effects, such as deepening voice and enlarged clitoris, so those can occur from really high dose of testosterone over prolonged period of time. And so we usually check the blood level about 3 to 4 weeks after we start treatment with testosterone, just to ensure that level is normal in the normal premenopausal range. So, a question we often get about testosterone: what about risk of breast cancer and heart disease? So, this was an observational study that looked at about 10,000 women who were taking testosterone therapy over 3 years. And those women were compared with similar women without testosterone. And this study did not show increased risk of breast cancer or heart disease, and actually showed that testosterone might be protective for those problems in certain age groups. So this was only 3 year study, and we know it takes long time to develop breast cancer. So we need longer studies, but so far the results are reassuring. So how do we prescribe testosterone? So unfortunately, in US, we don't have FDA-approved formulations for women. And so the solution is to borrow that from men. So we do prescribe FDA-approved testosterone for men at 1/10 of a dose. And the safest way to deliver would be gel or cream. And so the other formulations we don't use for the following reasons. So injections can create dose fluctuation. Oral testosterone can increase the risk of liver function, so and pellets can create really high supraphysiological level of testosterone. Now, what about those women who don't want to take testosterone or cannot take testosterone for whatever reason? So we have several other options. We have prescriptional medications that are approved by FDA for premenopausal women. So there are two of them, flibanserin and bremelanotide. And then we have old bupropion that used for depression, but also helps with libido. So all of those medications end up increasing dopamine in the brain, and that's how they work. One potential application for these medications would be to offset side effect of SSRIs. So SSRIs like Lexapro, for example, are often used for depression, and one of the side effects of those medications is decreased libido. And so these medications can help to reduce side effects. So education and sex therapy can be very helpful, and I have separate slide on educational resources and also on sex therapists directory. Stress management and cognitive behavior therapy, and also addressing genitourinary syndrome of menopause, such as vaginal dryness and pain. So the most effective treatment for genitourinary syndrome of menopause is low-dose vaginal estrogen therapy. And we are fortunate because we have many options to choose from over here. So most commonly we prescribe those first two options. So we have two types of cream, estrace and Premarin, and we have vaginal tablets such as Uvafem or Vagifem. And those two options are non-expensive because they come as a generic formulations. So, and then we have this insert called Imvexi. So it's a soft gel capsule, and it doesn't require applicator. Then we have estradiol. So it's placed in vagina every 3 months. So it's good for those patients who have trouble with medication compliance. And finally, the last option over here we have, it's not exactly estrogen, it's actually DHEA. We call it prohormone, so it's precursor. It converts into estrogen and testosterone at the peripheral tissues, but it's as effective as other options that I've listed here. So which one is the best? They all are equally effective, and usually it takes about 2 to 3 weeks to see improvement in symptoms, but maximum benefits we usually see in about 2 to 3 months. How do we choose the option? So usually number one, it's a patient's preference. Some patients don't like cream because it's messy and they would prefer tablets. And the second factor is the price. The last three that I mentioned here, they're all brand name and expensive. And so we have to take into account that fact as well. So lubricants versus moisturizers, what's the difference? Lubricants are used as needed to reduce friction during sex, and moisturizers used on a regular basis to maintain vaginal moisture. So a couple tips how to choose lubricant. So there are three types. There is silicone, water-based, and oil-based. First of all, no matter what type, avoid irritants such as glycerin, parabens, propylene glycol. And by the way, those commonly used brands such as KY and Asterglide have one of those irritants. Now, if partner has erectile dysfunction or if using silicone sex aids, then avoid silicone lubricant. So silicone lubricant can damage silicone sex aids. Oil-based should not be used with condoms, and those couple who desire fertility should use this special brand Pre-Seed that doesn't affect sperm motility. And I have some brand names recommended by this International Society for the Sexual Women's Sex Health. Moisturizers, as I've mentioned, they have to be used on a regular basis and they replace normal vaginal secretions. So they are as effective as topical estrogens for the pain, itching, and irritation. The only thing they don't do, they don't reverse vaginal atrophy. And I have a table here with the brands that are again recommended by the same society. All right, and as I promised, I have a page on resources. So this is a good website to learn about techniques and some other tips and tricks for singles and couples. And so I have these two websites with the sex therapist directory, and there are some books that might be good read for those who are interested.